Good afternoon, everyone. It is January 10th, Tuesday, House Healthcare Committee. We're going to do a couple just brief housekeeping things, answer any questions maybe people have looming from last week, and then our first, our only witness for the day, Nolan from JFO, will be here about 1:15 to walk us through a Healthcare 101. So the agenda is on the website. Hopefully everyone knew how to get there. And so this week is a lot of overview. So take it in, ask questions. We may run out of time for questions, which is fine. Just jot them down. We'll come back to these things. It won't be the first time anyone who comes in this committee this week will be here. They will come back. So keep that in mind. And also, Nolan has a hard stop at 3. And then I don't have a meeting until 3:30. So we can review the website individually. If anyone has questions, I can show you how to find things, reports, testimony, anything like that. Just we'll do that offline in a non-forum fashion. So a couple other things. Next week, we don't know what day. I think everyone got an email about this. We're going to have an evacuation drill. We're obviously not told when.
I thought it was the 17th.
It's the 17th as of now. I'm hearing rumors it might change. So just keep in mind what you're wearing, depending on the weather, although we won't seem to probably have snow or ice. But shoe-wise, if you get cold outside, have a jacket hanging out there so you can grab it. But, the intent is we get out quickly. So just be prepared for that. Couple other things. A couple of you have been sending around emails to everyone, which is great. We do have a House Healthcare email distribution. I don't know if people were putting in all of our names individually, but if you go to the 2 and type in House Healthcare, that email distribution will come to all of us. And Claire, can you just confirm that we're all on that?
Are all on it. I'm working to be added as well. So
Great. Wonderful. Thank you. Then the other thing before I get started, which is really important in healthcare, is talking about acronyms. So we tend to use a lot of them in healthcare. So I will try to remember to say, what does that mean? But if someone's using the ABCs and XYZs, please stop and say, what does that mean? And, what's the definition? I have a couple documents from previous sessions that I'll send out to everyone that has common healthcare words and definitions. And so that hopefully will help everyone too. But please stop us if we're talking in alphabet soup. Here, I think.
I don't need that. Oh, does it come from Ellen?
no,
Thank you. Oh, thank you.
I think that's it. Did anyone have any questions from last week or thoughts or anything we didn't cover, concerns? We're ready to get started?
I have one on this committee email. This is up to you. But I wouldn't use that email if you're asking a question like, help me with this particular bill. And why do I say that? I think those things are between you. You got to do your own research. And there's whatever many people in the room, they have a different opinion. So if you ask that, you're going to get 10 or 11 different opinions. And anyway.
No, that's a good point.
Yeah.
And better to have that conversation one-on-one, right?
Right.
And that's one of the benefits of being back in the building. We can talk to each other. And you'll often see, I'm sure this happened in human services too, at the end of some testimony, people are often small groups talking about whatever concerns or questions that they have. So that's a really good point. I would say the email distribution is, logistical things or resources or that you might find interesting that other people might want to have.
And also if it's the chair's birthday, you might wish her a happy.
Well, the problem is that's in August. So if we want to just pick a random day to
The
do my
vice chair
birthday.
has a birthday in April, so
Well,
maybe you can do that.
we could maybe do
I don't know
that.
the ranking member's birthday is,
So what's your birthday in August?
but I mean, that's the kind of thing you usually
Well,
use,
Can we
Yes.
hone in
Yes.
on a day in April?
Right.
Can we get a little closer than just April?
19th.
Right, that's-
Oh, boy.
And we're gonna, and we're
Anyone else
gonna,
on the 19th?
and we are
What a
gonna
great day.
send around a contact list too. So we'll work on getting that out and collect everyone's birthdays because it is fun to celebrate now that we're back in person. And I'm glad you're here because you're my next topic. And then we'll go into Nolan. So we have a position on the committee that is clerk. So the clerk is the one who takes all of our votes and records them, makes sure we all know what to do when we're reporting a bill, how to get it introduced to the clerk's office and the whole process. So Mari was the clerk last session, and I did ask that she be the clerk again this session. And so she has agreed. So just want to say thank you.
Sure.
And if anyone has any questions about those processes, she's really knows what she's doing. I thought because we're going from a process that we did not in person to a process we're doing in person, it would be great to keep the continuity with Mari. So
And Claire is a helpful part of the process too.
yes, there's a helpful part of every process. we
Every
do.
process.
Hey, Lori,
Yes.
one thing you might mention to the new folks is if the house healthcare email list has changed, then they're getting the ED wait times.
Oh, good point.
You might just bring that up, why that's important.
Yep, I will. Thank you for that. So last year, we put in a request, I think it's been over a year maybe, that when we started seeing a lot of people waiting in emergency rooms for mental health treatment, and people waiting days. I mean, you've all read the news, right? People waiting days or weeks. We had required DMH, Department of Mental Health, with the Vermont Area Agency of Hospital, VAHS. I don't know what it stands for, but all of the hospitals belong to an agency. And so they send us weekly point in time reports that show by all different categories how many people are waiting. They do a monthly synopsis of the same data. So if you haven't received that, you'll start receiving that. It is on my list of topics for us to talk about at some point, because I do feel like there could be a time to look at what other type of data, different data, better data that we should be getting. These are very time-consuming reports for the hospitals and the person who's organizing it to do. So I'd like us to have that topic of conversation. So take a look at them over the next couple weeks, and I would say in a couple weeks, we'll have those folks in to talk about what we can do better. Thank you, Art. That was helpful.
I'd recommend saving those reports when you get them, so you can track,
Yeah,
that's just what I do, I don't know. But
it is interesting to see the numbers, unfortunately not come far down, but they do fluctuate. And I will say we're using first names, so hopefully that's okay. It's going to be very informal today. When Nolan comes to the table, it'll be interactive. So we're just going to use first names. That's okay. Go ahead, Jim.
I was going to say, I actually responded to that email regarding waiting times and asked if they could, on the 6-month report, show us how many people were waiting more than a week, because that was the most deeply disturbing thing to me, the idea of any patient waiting in an emergency department for more than a week. And that's something I really would like to track.
Great, good. And you sent that email out?
I did, yeah.
Great, perfect. All right, so I think, Nolan, we're ready for you.
I'll come up there. I'm gonna share my screen and I'll walk over. This is the first time I ever Zoomed in the room. Button to adjust. Good morning.
Morning.
Good afternoon.
Yes, good day. Good day.
Cheers.
Cheers. For the record, I'm Nolan Langweil. I'm with the Joint Fiscal Office. This will be my first official testifying of the year. I'll warn you, if I have a dry throat, I'm coughing. 3 weeks ago, I had that cough that everyone had, but I'm not sick. I tested for COVID. I'm negative. I don't have anything since saying that. Because in this world, you have to sort of wear your health status on your sleeve.
And I have a Halls if you want it.
Thank you, and I do too, and I have lots of water.
Okay, good.
Before we start, I'd like to introduce a colleague of mine. We have Ed Barnett. He is with the Joint Fiscal Office. He is new this year. He's part of our revenue team, and maybe you could say what areas you're kind of specifically covering.
Sure, yeah, so I will be working on cannabis revenues and taxes, also kind of pinch hitting on the salt capital reduction, and then also looking at fees and issues that happen in the session.
Great, welcome.
I'd like to introduce him. This is his first session, so he's just sort of like watching me today to learn all the things that you don't do when you're testifying. So he's unlearning all the bad habits before he's learned them.
Yes, thank you.
The other thing I'll say is this presentation is a little bit different than my normal ones. It's very long intentionally. We're not going to spend every moment on every slide, but what I like about this is it's designed that if you have a hard copy, which I believe you all do, it's going to be a reference document. So you can be like, oh, how many people were this? Or what was the estimated costs for Y? It's sort of a good 101 like document that you can go back to, which is the reason why it's long. But most of the slides I'll kind of blow through pretty quickly. And then when I come to one that's specific, I might hone in on it. So,
And just to reiterate, we will have Nolan back several times and he's frequently in the room. So there'll probably, we'll go through this and then in the middle of the night, you're going to be like, oh, wait, I have a question about that. I mean, we'll be able to get to all those. So
yeah, this is meant to be high level. And then some of these concepts I will come back and get more depth in. The other thing I'm going to say on this, and I will say this before a lot of my other presentations, is for those who have never sort of delved into healthcare is complicated. And if you don't get a lot of these concepts the first time, it's not you. If you don't get a lot of these concepts the second time, it's still not you. However, if you don't get it the third time, it's actually still not you. This stuff is really, really complicated. So I just want I want to demystify it. Like, this stuff is complicated and you're not expected to understand it right away. The other thing I will finally say, and then I'll actually start moving on. I'll take questions as we go, but also I invite anyone, if you want like a one-on-one on any of this stuff or specific, Representative Peterson will tell you that I worked with him his first term session over the phone. I'm happy to sit down with any of you on any of these subjects and kind of get in more depth, help you get to a space that you want. That's what I'm here for. I'm a resource, so use me. So this is the quick disclaimer. I throw a lot of numbers and figures out. There's a lag in a lot of these data. Some of them are from before COVID. Some of them are after. I'll flag it, but just keep in mind that COVID really changed up a lot of our traditional trends on a lot of different things. So I just sort of feel like I have to say that. So if you see a number from 2020, it says this is how many people were uninsured. Well, that's probably different now, but it gives you a sense of where things are. So I break out this presentation into kind of 4 parts: patients, providers, payers, and regulators. So we'll start with patients. I always start really high level. Again, I feel like I'm going to have too much slides because I'm trying to tell a story. So this gives you a sense of like a Vermont population. You can look back to 2008, 2020, and you can see until 2020, there really was very little change in our population. Obviously, we've heard the stories about how COVID changed all that, but there wasn't a lot of change. And you can see that we have a lower birth rate. Our birth rate is lower than our death rate. this is kind of the conversation about population. This sort of shows how how we have our population in general hasn't changed, but if you look at the 0 to 17, it's kind of going down, where 65 plus is going up. So when you hear the conversations about how we're an aging population, this is sort of the graphic that sort of tells that story. Again, I'm just starting high level. This slide really just is more of a reference to give you a sense of these are the leading causes of death as provided by the health department in 2020. Again, this is just something that you can have in your document.
Can I just want to stop you real quick? So just for the new folks in the room, so we're referencing 2020 data in most of this. You might be thinking, well, we're just started 2023. Why are we behind? Healthcare data, and Nolan could probably say this better than me. There's a big lag with a lot of the data that we have for healthcare, and it's just not Vermont, it's across the nation.
Yeah. For certain things, like we only do our surveys, for population stuff, you only do your surveys every couple of years, right? For our healthcare expenditure data, usually we have to wait till the year ends, and then we get all the data in, and then take a year to scrub it. So a lot of the data that I'll throw out from the Green Mountain Care Board, which by the way, Susan Barrett is here from the Green Mountain Care Board, there's often a 2 to 3 year lag on some of that data.
I'm just curious, I'm just looking at 55 to 84. So these numbers only add up to like 50 or 60%. Like, what's everyone else dying there?
So I just flagged all the big ones.
Yeah.
If you looked at
Whole list.
it's everything.
Everything else.
I just sort of listed the big ones.
Okay.
How many people died tripping on the sidewalk, I'm not going to
Accidents,
do that, but
yeah.
I want to show you that, look, a lot of people die from accidents, and we have a large, as you get older, then it's more like diseases of the heart. When it's younger, it's accidents, it's suicide. When you hit middle age, it starts getting into the mix of accidents versus more chronic illnesses. So it's really just meant to be a high level flag. We don't really cover a lot of this stuff in this committee, but I just wanted to sort of.
It could be that famous DSM code struck by duck subsequent encounter. That could be the reason.
Indeed.
Just a quick question. Neoplasm, is that cancer?
Yeah.
Okay, I just never heard that term before.
That's how that's how they sort of flag it in, or to describe it in vital statistics. That's the term I'm looking for. They have that report.
It's the malignant part that's important, not the neoplasm.
Yeah.
So now we're getting into the numbers a little bit, and I'll often show you the difference between Vermont and the United States, just so you can get a sense of grasp. So the total healthcare expenditure in the United States was $6.3 trillion. In Vermont, total healthcare expenditures were that's not right.
Trillion?
Yeah.
That's billion, that's not right. Oh, yeah, that number's wrong. Okay, well, there's the first thing I gotta fix. Oh, wait, I'm sorry, I'm reading it backwards.
Yeah.
I'm reading it backwards, sorry. Vermont in 2020 was 6.37 billion. And in the United States, it's 4.1 trillion. Sorry, thank you. I'm reading it backwards. I'm being a little dyslexic today. I don't mean that in a derogatory tone. So you can see our average annual change from 19 to 20 in Vermont, it went down 2.3%. That is the COVID effect. But nationally, it still went up 9.7%. Couldn't tell you why, but it's nice to see. It's interesting to see, how there are some differences between our population versus the national population. Our average annual growth was 2.5. In the US, it was 4.4. So we can see that our growth in expenditures is lower than the national average. Our per capita spending is also lower than the national average, which is $9,900 per person. In the United States, it's almost $12,000. And you can see again, our average annual change over 1 year went down 5%. It still went up 10% nationally. So these are just kind of flag how we, how we stand up these kind of things versus the national average.
Quick question, does the $6 billion include federal funds or just state funds?
Total spending on Vermonters, on Vermont. So I always come at things, this is from the healthcare expenditure analysis. They break everything up by how much was spent on behalf of Vermonters, regardless of where they are. So if you're skiing in Colorado and you break your leg, this counts in this number, versus how much is spent in the state is a different number that they use. That would include, I'm in Colorado, I break my ankle, it doesn't count, but someone from New York who breaks their ankle still, it does count. So I'm using the residents. So I'm using how much was spent on behalf of Vermonters. So $6.3 billion on behalf of Vermonters. That would include Medicare. That would include any spending regardless of where it comes from. So it's a great question. And I'll differentiate that throughout. This shows sort of, again, the trend. And you can see that generally our healthcare expenditures have been going up. They never go down. And then you can see in 2020, for the first time, expenditures actually dropped. It was 6.5 billion in 2019. They dropped to 6.36 billion in 2020. Now, is that we're going to see it spike again in 21 or 22 or 23? Probably. But this is the pandemic effect. Do this again for illustrative purposes. Again, you can see that in Vermont, our expenditures went down, but nationally they still went up. Couldn't tell you why. It could be because maybe increase in federal fundings across other states. I just want to show us relative to the country.
Just to be clear, and Lori, I didn't quite hear your question, but does this include personal and state expenditure?
Yeah, this is total spending.
Total spending.
Doesn't matter where it comes from.
Doesn't matter where it comes from. Okay, thank you.
Exactly. But these are great questions. It means I've trained you well. Because when we start getting into budget, we're always having the conversation. Are we talking state dollars? Are we talking federal dollars? So the fact that you guys are the veterans are asking me that question, makes me feel like I've been doing my job. And soon you will be asking those questions. So we'll move into the providers. And so what I do here is I try to real quick talk about the different providers in the state, some of the stats around them. You'll hear from some of those specific associations that will get more into the weeds about what they are. But I want to just sort of here's the landscape that we're discussing. So hospitals. We will be talking a lot about hospitals because hospitals are more than 50% of expenditures in the state. I believe 50% or more. If they're not, then I'll get an email saying the number was wrong. That's the other thing that's great about live is I'm sure I'll be getting pinged from people who are listening and said, Nolan, you got the number wrong. So, which never happens. I never get it wrong. So in Vermont, we have 14 hospitals, only one of which is a level 1 trauma center at University of Vermont Medical Center. In Vermont, every hospital is a not-for-profit hospital. I don't know if there's other states that have that level of designation, but they're all not-for-profit hospitals. I'm going to mention Dartmouth Hitchcock because they are a part of our health system. They're in New Hampshire, but we don't regulate them. Just like New York doesn't regulate us because there's a percentage of their population that comes over to UVM. I'll actually get into that in a future slide. Then we also have the VA hospital in White River Junction, and then we have the Vermont Psychiatric Care Hospital in Berlin and the Brattleboro Retreat, which are psychiatric hospitals. So this is sort of our landscape of hospitals. This is where I get into a little bit of stats about hospitals. I don't know if I like to call them fun facts because this gives you a sense of some of the different pieces of them. So spending on hospital care was $2.2 billion. Remember I said it was $6.37 billion. So it's 2.2 of that was on hospitals. So it was less than 50%. But this is a 7% decrease from 2019. So we did hear from the hospitals during the pandemic how they were losing revenues. You'll be hearing about some of the hospital financial health. But there was a drop in hospital spending for the first time that I can remember. This accounted for 34.5% of all healthcare spending in Vermont. So there's the stat that I already corrected myself on. There were total 214,605 visits to Vermont hospital emergency rooms. That was actually a decrease from 2019. Also, again, that's the pandemic effect. UVM Medical Center accounts for 23% of all emergency room visits, 12%, and then followed by Rutland, which is 12%. So you can get a sense of how big and how important the University of Vermont Medical Center is to our healthcare system. 12% of those emergency room visits resulted in an admission and an inpatient discharge. Roughly 1/3 of those visits were paid for by private insurance. So again, I'll get into a little bit later about who's paying for these things, but I just wanted to flag, you can see that private insurance is a bigger payer on hospitals, but I have another slide later that shows you that Medicare might be a bigger payer for other stuff like nursing homes and stuff like that. So again, we'll get into who's paying for what.
Just to clarify that number there. So when it says 1/3 of visits are paid by private insurance, that is that 32.3%, and those other things are separate from the 1/3 there?
Yeah.
Okay, so
different payers, we have Medicare, Medicaid,
Yep.
private insurance, other payers. We had 41,500 inpatient discharges, those people that were admitted to the hospital and then discharged. Again, this is also a decrease from 2019. I don't know why I put so many decreases here because that seemed to be the theme, but that's where I was at when I did this presentation. And then I kind of get into some of the stats of like, you know, those over 65 or older accounted for half of those inpatient discharges. So again, you can start seeing that how age is a predictor of those pieces. Medicare was a principal payer 50% of those times. The average length of stay is 5.3 days. And University of Vermont Medical Center accounted for 45% of all inpatient discharges in Vermont. So there were a total of 114,000 outpatient visits. Again, UVM Medical Center accounted for 45% of those. And again, Medicare was the principal payer 50% of the time. In the future, I'll get into the payer section and you'll see how that breaks out, who's paying for what.
Hold on, Brian.
Just, this is in 2020, it's not adjusted to factor for the impact of COVID, right?
Yeah, we don't have that data yet.
So the decrease is just,
That's a 1-year decrease from the
between
previous.
2019 and 2020.
Correct. So, but we don't know what 21 or 22 look like.
But I mean, 2020 is when everything shut down.
Right.
Yeah.
So like everything came to a screeching halt in March for the remainder of 2020. So could the decrease between 2019 and 2020 be simply because we shut the healthcare system down?
Exactly for that.
Okay, I just want to be really clear because like,
Yeah.
it's not like we're saving money or saving,
No.
or doing better
That's
jobs.
why I say it was the COVID effect.
Yeah.
You know,
Okay, if you said that, I'm sorry, I missed the COVID.
we'll get the newer expenditure analysis probably in March, and we'll see like how things either leveled out or spiked back up, or might not see it till 23. We don't know, but absolutely, yeah. I mean, I'm glad you're actually saying it. We can say it over and over again. It's good to say. It's the COVID effect, right?
COVID effect, the COVID effect.
COVID effect.
Alyssa?
Yeah, not a question, but just, can we get a, not now, but soon, can we get a breakdown of Vermont's population by age? I mean, you've got 50% over 65. I have no idea what percentage of Vermonters.
I'm sure we have that. I'm sure we probably even have it on our website, but I can get it to you.
And I know you're a stickler for detail. You have a $sign in front of your 214,000 visits.
I saw it too, but I didn't want to say anything. Just let
You know, there's always something.
I know he would want to be corrected on it, because you want to be perfect.
You know, I put it there purposely. I'm just testing. Who's paying attention?
Are they really reading it?
They're really reading.
I'm gonna send you an email with the other changes I noticed.
I know you will. So this is just a stat that just kind of show you where people are coming from. So we talk about in-state and out-of-state migration. This is total inpatient discharges, and I wanted to sort of flag like what percentage of each of these hospitals population of discharges were from out of state. So statewide, most of the people who are coming to our hospitals are from Vermont, but we have 9.3 are coming from New York. We can see we have a little less than 1% come from Massachusetts. You got New Hampshire, and then you have other, and you can see depending on where they are in the region, what sort of like what their payer mix, how many people are coming from in-state versus out-of-state. What I don't have is how many Vermonters are going to Dartmouth-Hitchcock, again, because they don't report that data to us. I would imagine it's quite a bit.
So
Go ahead.
I just want to clarify that I'm reading this right. So for instance, Southern Vermont Medical Center, 29% of their inpatient discharges were from non-Vermonters.
Correct.
Thank you. Go ahead, Leslie. And then Art.
Never mind.
No, when you say inpatient discharge, does that mean someone who came in, had something done, and then
Yes.
they came out?
Correct.
I'm wondering why you categorize them that way.
So we measure things by inpatient and outpatient discharge. So inpatient would be someone who came in and had a serious
Stayed overnight.
and that's where a lot of our healthcare dollars are spent. And then outpatient would be you come in and you get a mole removed, right? I don't know if I can phone a friend. Can I phone a friend?
Those.
I mean, if you want, I mean,
Susan, can you?
Yes, Susan Berry, Green, Executive Director, Green Mountain Care Board. Hello, everyone.
I mean, it's one way of measuring them.
Okay,
It's-
so,
We don't have a better way. It's
all right.
I don't know if you think.
Yeah, that's fine. I just found it curious, that terminology, inpatient discharges, is the way you count it, which is
As
fine.
opposed to inpatient versus outpatient, you're focusing on the discharges. I think it's just drilling down into the specifics, as Nolan said. And as you progress in your education, we do have more data on inpatient and outpatient. And just as a caveat, there is more and more outpatient in the hospitals now than there are inpatient.
Okay, there's more outpatient than inpatient.
Now, yeah.
And also, like, there wasn't a thing that said X percentage of overall services.
Right.
I didn't have that.
Right.
But most, yeah.
Joe.
This is a bit of a morbid question, but is death considered a discharge?
Yes.
Yes.
Okay.
Oh, sorry.
We help each other around here.
That's where the
Good question,
professionals come in. We also have our federally qualified health centers. The organization that represents them in the state of Vermont is called Bi-State Primary. I believe you'll be hearing from them soon. But what an FQHC is, they're an important part of our primary care system. They have a different reimbursement that's sort of federally designated, so they have to follow some different rules. They have a larger regulatory burden, which have like 90 requirements that are tied in order to maintain those statuses. In return, they get I believe they get like a higher Medicare reimbursement. Just they're reimbursed differently, but they function for a different reason. They function really as a way to help proliferate primary care services in the state. And I'll leave it at that. Bi-State will come in and they'll tell you more about who they are and the role that they serve. But it's important to sort of get that term out there, FQHC, FQHC, FQHC. This is quick. It just shows you a map of where they are, how many there are. Again, I'll let the Bi-State come in and tell you more about themselves. We also have our long-term care. That would include our nursing homes. These numbers in nursing homes change, but these were the latest numbers that I had. There were 37, 34 participate in Medicaid. There was about almost 2,900 beds, or at least there were as in October. We have 10 home health agencies. We have 17 assisted living residences. We have 100 residential care homes, and we have 10 hospice programs. So again, these are just sort of drilling down to different types of facilities, services, programs that are in the state that provide important care to Vermonters. Mental health.
I'm sorry, and long-term care is the jurisdiction of Human Services.
Mental health, we have our providers. They include our 9 designated agencies. You're going to hear from an organization called Vermont Care Partners. They represent what we call DAs, designated agencies. They provide comprehensive mental health and developmental disability services throughout the state. I won't go into too much more about this because you're going to be hearing from the department about mental health very soon. So I'll defer to them and focus more on some other pieces. Workforce. I added these slides in this past biennium because there was a lot of discussion about workforce. It's who gives us the services that we need. It's our workforce. I recently had an issue where after the pandemic, I used to be able to call my primary care practice and get right in that day. Now they barely can get them to answer the phone. And it's not because they're not doing a good job. I just know that they're under-resourced. And that's a whole other, they're doing a great job. Yeah.
On the previous slide, I think it's important to, Representative Portis from Lincoln. I think it's important to, when you're looking at the bed numbers, those are nominal numbers, 25 at Vermont Psychiatric Care Hospital, et cetera. But
yes,
it doesn't mean staffing plays into that.
Right.
If they don't have the right staffing mix, depending on the acuity, and and the number of staff, then the actual number might be lower than 25.
Yes.
And good point. And Department of Mental Health will be in this week and they will give us an overview of just that. So this is the number of beds we have, but because of staffing issues, these are closed. This is the number that's open. So that's part of the issue of why the flow isn't working through our system, that there are quite a few beds that have been closed. Fluctuates, but there's a lot.
So this number here is physical beds, not staff beds. Okay.
It's the amount that they're
All right, I wanted to
licensed.
make sure that, okay.
It's actually the amount that they're licensed for, I believe, but at any given time, yes. And I thank you, Representative Cordes, for filling that in.
Would it be fair to say that the number here is the maximum potential beds?
Sure.
Yes.
Okay.
Yeah,
You're
maximum
right.
license beds.
Yeah.
Yes.
What does that add up to?
So workforce, so I tried to throw in some workforce numbers in here. There's a lot of numbers here, only because I'm trying to tell a story again. And again, these data are all some from 2018, from 2019, but it's all pre-pandemic. And you can see the breakdown, like, you know, how many people work in primary care versus specialty care. So you can see, you know, 25% of our physicians were in primary care, 75 were in specialty. You can see the trend in primary care was that we're having fewer and fewer each, you know, I put both the numbers and the FTEs. And you can see the number of people providing that has kind of been going down. Whereas if you look at our specialty care, the number of specialty care has been going up. So I just wanted to more tell the story that where the trends are for those particular things. One of the things that conversations we often have too in this committee is when we talk about medical school and training, well, how many of those people are staying in Vermont? So we know that 33% of our physicians, at least in 2018, attended medical school or had a residency completed in Vermont. And then I also talk about age, 30% of those are under 44, 30% are over 60. So again, just to give you a sense of not just who's in our workforce, but what that might look like in the future as we start aging out. So again, I'm just trying to tell a story.
Leslie?
I don't know if you're going to refer to the 1,112 physicians that are not practicing.
Yeah.
That is really interesting. And I'm kind of wondering if we can figure out who they are. I don't know. Are they primary care? Are they specialty?
So this is from a health department survey that they put out every several years. I don't remember in that document if they sort of get into detail about who, what, and why. Sometimes people are, getting older and they want to keep their license, but they don't want to practice. Sometimes they are keeping their licenses, but they're in administrative functions. I mean, it's hard to say. Sometimes they moved out of state, but they're keeping their license in state.
Wouldn't this be made up of a lot of Dartmouth Hitchcock providers who provide care in Vermont, but you keep a license in Vermont?
Could be. I don't know the answer to that
Yeah,
story.
I just wonder if it's a resource. I mean, it's 2018, which to me sounds like, the Stone Age, but,
Yeah.
so that's what I'm wondering.
That's a
How do is there a group resource there? That's all, because we know we were having
There
trouble.
is, if you go to the health department website, there is there's a physician, they do surveys for every different healthcare provider, and I don't know if that information is in there. I don't know if they ask the question in the survey, why not? I get the sense that it's really more for census purposes and not for policy purposes, so. I add physician assistants to give you a sense of, like, again, same story. They're an important part of our healthcare system. We don't really talk about them a whole lot. I will say that there are no physician assistant education programs in the state. So if you have a physician assistant, they're all coming from out of state.
I didn't realize that.
So,
And just real quick, when you're done with the workforce, I'll add my comment. You keep going.
we get in nurses. Again, I'm just trying to tell the story to show you. We have, for instance, APRNs, advanced practices registered nurse. We've got 868, 84% are practicing. The median age is 49. Again, I just wanted to sort of only 23% are full-time. Again, I'm just trying to tell the story of the various pieces of the workforce. Again, this is meant to be a reference. And if this becomes a subject of the future, you have this all in one place.
And it will become a subject. So this committee and the body passed out legislation last year. It was S11 was the bill. I don't know what act it became, but it put a lot of money into workforce. So we're going to get an update on that fairly soon, I hope. And, this committee has worked on workforce the last couple bienniums, and I would think we would continue doing that. So it's obviously really important.
Nolan, does this figure include what do you call them? The nurses that come from out of state?
Travelers.
So if they're licensed in Vermont, it would count them. If they're not licensed, I don't know. I mean, Representative Cordes might know about how that works if you're a traveler, if you need a license in that state.
Depends if you're part of the compact, the nursing compact, and there's only about 17 or 18, maybe more states that are part of the compact, you only need to be licensed in your home state, but you need to have the home state compact license, not an ordinary license. And then everywhere else, you have to apply in that state. And every state process is different.
So what would the answer to Topper's question be? So if you're a traveler not associated with the compact, you would be in this number because you would need a license.
You'd have to have a license.
In Vermont.
Yeah.
Yeah.
That would be a good question for OPR, though. I don't know if they separate those out.
Right. And just so the compact, we have a couple compacts we've entered into, one with physicians, one with nurses, meaning it's a agreement between states that want to come into it on, I'm a nurse in Minnesota. They have they signed into the compact. Correct me if I'm wrong here, Mari. And Vermont has a compact. I want to come to Vermont. I just need a license through the compact, and it really quickens the process to be able to start practicing here in Vermont. So we've done nursing and we've done physicians. And there's some more out there that we may be taking a look at.
I don't remember. Do we have a report coming from OPR about compact usage since we implemented it?
I don't think so, but we could ask them when we implement. Yeah.
We do. Licensed clinical social workers.
We did not do we have not done the compact for, yes, we did.
Mental health.
We did, yes, we did that one as well. Yep. And then there's a counseling compact that I think will come through as a bill this year.
Occupational therapy is.
There's so many of them.
Can I ask a small favor? I was just realizing, for the new members, could you tilt your nameplates a little bit so I can, not all the way, just enough that I can see the new ones, so I can recognize your names. I know the ones who are here.
I'll get you.
I'm old.
Oh, you're old?
Not old.
We're the oldest,
You're
right?
seasoned.
Me and Lori.
Right.
Actually, Topper's got the seniority here.
What?
You're the most senior member.
Committee too.
Yeah, but then me and Lori.
Representative Topper is the only person at this room who's been here longer than me.
On Earth or in this legislature?
In this room, I said.
I'm just teasing.
So,
All right, keep moving.
all right. Dentists. I know we don't talk a lot about dentists in this committee, but it does come up every so often. So again, the same story. We have 389 dentists. There's you can see again the age distribution of them. Number of dentists has relatively stayed the same, but more dentists are providing 30 hours or more. So that's an increase of 3.3% FTEs, which is a good thing. I think it's, and you'll hear conversations about access to dentists, particularly for different payer sources. Folks who have Medicaid often have a harder time finding a dentist. Reimbursement rates are below the floor, but that's a whole other conversation. So,
And again, this data is 2019, so it probably has changed.
Right.
So if we don't talk about it here, dentists, is it Human Services talk about that?
No, it's us, because it's healthcare, just.
We haven't talked about it, okay.
Yeah. So now we're going to.
I know this is 219, of 2019, when did the dental hygienist assume some of the dentist work?
That's a great question. I don't know the answer to it. The question I have myself is whether those programs to the technical institutes and colleges have actually started. It's not only started up, staffed up, but started turning people out. And that was a big piece of it. And I don't know the answer to that. I can look into that. But I don't know the status of the dental, right? The dental therapist, is that what we call them?
Right.
So the dental therapist, which was legislation that was put in
A couple of years ago.
before I was here, or maybe in the beginning, is that what you're talking about? So though that program never started, there was some work done with some legislators over the summer to work with the state colleges to see how we can get it started. So we will probably be looking at that this year to make sure that we do push that. But the dental therapy program never started.
Interesting.
Now we get into the fun stuff. I mean, it's all fun, don't get me wrong. All right. We're going to talk about insurance coverage and provide payer. This chart is sort of the starting point of how I think about this. So you can see we have private, commercial insurance, we have our government, and then the military insurance is sort of its own little thing because it's government, but it's private insurance, but it's just sort of its own thing. But we'll be talking a lot about Medicaid, and we'll be talking a lot about private insurance and how that's broken up. And don't worry, the slide you're thinking of, I'm coming to.
No, before you even go there, can you just define Medicaid and Medicare?
I do later.
Okay, perfect.
Do later. And I'll get into more of the weeds of each of these actually,
Right.
Medicare. Again, this slide is meant to tell a story. If you look at 2008, you can see we had 60% of folks had private insurance, and then if you combine government, so Medicare and Medicaid, it was 30%. If you fast forward to 2021, it's 45% of Vermonters are on some kind of government coverage, and private insurance has decreased. So, but the story that's telling there is we've got more people moving from private insurance to public insurance in some form, and it could be they're aging into Medicare, and then we've expanded eligibility, or we've had other different things in Medicaid. So, sort of the story that I just wanted to tell you, and this trend goes back to 2000. I looked at there was no year where where there was an anomaly from this trend. I like this slide. This is from the Green Mountain Care Board because it talks about government versus private, but it's different depending on what service. So you can see if we're talking home health care for nursing homes, well, the majority of that's Medicare and Medicaid. But when you start moving into like physicians and hospitals, well, it starts breaking out to 50-50. Then you start getting into like dentists and drugs, and you can see medications. You can start seeing that private starts taking over. So the provider depends on the service, and I just like this slide because it tells that story.
Joe?
I'm just going to say mental health, 100% paid by government funding. I'm just a little confused about that. Does that include like therapists and counselors and things like that?
Therapists, it's a great question because, my private insurance would pay for a therapist. Yeah. I think this is probably more like inpatient psychiatric care, those kind of things. That's a great question. I don't know the question to that. The answer is a great question. But this is how they've categorized it.
So we will have Green Mountain Care Board in. Joe, if you remember this, we can ask them.
Thanks.
So private, commercial. So I'm going to start moving into different payers. So I'm going to start with private and commercial. Most of our private insurance is employer-based insurance. So we think about things in terms of employer-based. Then you have what's known as the individual market, which is basically people who buy private insurance not through their employer. And then the military, again, it's its own little thing. And then under employer-based, we break it out. We have what's called self-insured. Some people call them ERISA plans. ERISA, just as an aside, is a federal law. I couldn't tell you what it stands for. There's a funny acronym, employer, retirement, blah, blah, blah. It's a federal law that basically dictates sort of the criteria around how they're regulated. The short end of the story is if it's a self-insured ERISA plan, we do not regulate it at the state level. And I'll get into that in a future slide. But a large percentage of our employer-based insurance are ERISA plans. And that might be like, for instance, I'm thinking of IBM. Well, it's not IBM anymore.
Global Foundries.
Global Foundries, they have a self-insured plan. So we don't regulate their health insurance. I'll get more into self-insured plans in a future slide. But then we have the insurers. So you're going to hear groups, large group, small group, large group, small group. And that has to do with a small group, I believe, is 100 or less, and a large group is over 100. We regulate those. And then in the individual market, we have, again, we're going to get into the weeds, but this is something that you guys will be working on. We have what's known as qualified health plans and reflective plans. And this gets into the Vermont Health Connect and the exchange and what plans are bought on the exchange versus off the exchange. And we won't get into that today, but just know that that's an individual market plan. That gets into who can get a subsidy and plans that don't have subsidies. So this is a slide actually Representative Hoden that I suggested I added. If it's blue, or any shade of blue, that's a segment of the industry in which the legislature has some kind of regulation. So for instance, we don't regulate Medicaid because we, the state, we operate Medicaid. So the legislature has influence in Medicaid because we, have influence over Medicaid policy and the budget of Medicaid. And then in terms of the individual small group and large group, well, that gets into regulating the plans. And you'll hear from the Green Mountain Care Board and you'll hear from Department of Financial Regulation. Those are two of the state agencies that have regulatory powers over insurance rates.
And so this is like Blue Cross Blue Shield, MVP, Cigna. I'm sorry? That's who we're talking about here. Go ahead.
Maybe this is a dumb question, but I'm trying to understand what regulate means in this context. And the reason I'm asking that question is, I guess what I'm trying to understand is, it would be my assumption, which may be a wrong assumption, that if, a private plan, for example, is essentially a private contract, but we regulate private contracts. If something is against public policy, then, it's not valid as part of a private contract. So I guess I'm trying to understand what do because if we were to say X is illegal, they can be like, well, I assume they couldn't be like, well, we're a private plan, so you can't tell us X is illegal. So what does regulate mean here, or is my assumptions incorrect?
You are a lawyer, I can tell. So there are criteria for which state insurance plans in the state of Vermont have to operate under. If they're regulated by us, they have to cover certain things. They can't deny certain people and situations. So there's those kind of pieces. Particularly in qualified health plans, they have to have certain criteria. If, like in the state of Vermont, we might say, okay, we've mandated that you have to cover colorectal screenings. Well, you have to cover colorectal screening if you are a plan regulated within the state of Vermont. We also, the Green Mountain Care Board, they'll get into what they regulate, but they regulate the rates. So they have to provide this whole budget about this is what goes into our rate filings. And the Green Mountain Care Board says, well, that's too high, or that's too low, or you have too much going in the reserves or whatever like that. And then Department of Financial Regulations, their pieces, they look at solvency. And so those are the pieces, the kind of things that are looked at in order to, and they have to be approved. The plans have to be approved in order for them to make it to the market. So that's the level of regulate that if you want to get deeper in the weeds, then I would want Jen or Ameren here. But that's, some of the examples of the way we regulate. So yes, they're a private contract, but they have to operate within the confines of state law and federal law, but we just manage the state.
And the not regulated ones, what could we, if anything, regulate of the not regulated influence?
So self-insured plans where we can't because of ERISA.
Okay.
So federal law preempts us.
Okay.
I know you'd understand that. And then Medicare. We don't regulate Medicare, that's federal. And then military. Military is military. It's federal insurance plan.
So federal preemption is essentially the reason for those. in the white, it's because of federal preemption there.
Yes.
Got it,
Yes.
cool, thank you.
So I think what I really wanted to show when I asked Nolan to put this together is, and we'll see numbers if not here in other presentations. I mean, you're looking, if you look at that whole pie as people in Vermont, less than half are what we can affect, the lives that our decisions affect, which, you know, is, you'll see as we go through things we want to have people do, it affects our decisions. So I think it's really, really clear. And I think more importantly, when you have constituents call you and say, I'm having trouble with X, Y, and Z with my health insurance or my health care, it's really important to find out where they get their health insurance from.
Yeah.
Because if it's Medicare, I would immediately send them to one of our congressional offices. It's not anything we can really help them with. So I will harp on this. You'll probably be tired of me saying it by the end of the session, but this is really important piece of our work to understand.
Yeah, and to that point, so if someone came in, if there's a bill that says, I want to mandate that we cover, you know, hearing aids, perfect example. And we did do that, we'd only affect this much of the market. All that wouldn't be affected.
We did affect Medicaid.
We can, that's a separate
piece. You have to have a separate line on that, but.
Yeah.
You're right with a lot.
And then maybe we can do that, or we definitely do that. That's a different consideration because we have to pay for it.
Right.
Where these, you know.
Right.
Yeah, we're just telling people what to do.
Right.
Yeah, so then we can't do anything about those. So this just give you a sense of our reach.
Brian, did you have a question?
Well, it was a point of information, just like that I wanted to share what ERISA meant.
Oh, yes.
It's Employee Retirement Income Security Act of 1974. And I also learned from the Department of Labor website that it was amended many times. So it can and has been changed. And it was amended by COBRA, the Consolidated Omnibus Budget Reconciliation Act. It was amended by HIPAA, the Health Insurance Portability and Accountability Act, as well as the Newborns and Mothers Health Protection Act, Mental Health Parity Act, Women's Health and Cancer Rights Act, Affordable Care Act, and Mental Health Parity and Addiction Equity Act.
So it keeps getting amended, but
Yes.
by the federal government.
Yes, by the
not
federal
by
level,
us.
exactly.
Not by us.
It takes acts of Congress to change it, basically.
Leslie? Thank you,
So I
Brian.
just want to make sure I'm getting this. I think I am. Even though we think we have control over Medicaid, there's a lot of interaction with Medicare. So a lot of the decisions, I mean, we say if we make a change, then we lose federal dollars.
It depends on what we're doing. Because and we'll get into our waiver and Medicaid rules later on, but there are things that we can do and policy decisions we can make and say, great, we can get federal match. And then there are things we can do, but we won't get federal match. And that obviously has a big influence about our decision because of the budgetary impacts of us saying, okay, well, where do we get the money from then? And then there's just some things we can't do. So yes, it depends on what it is we want to do.
But there's this intersectionality there.
Between Medicare and Medicaid. Well, a lot of the reimbursement rates of Medicaid are based on a percentage of what Medicare, so maybe that's what you're thinking of.
Yeah.
The other thing I'll say is, and I'll get into it a little bit later, but there's a thing called dual eligibles. And those are people that are eligible for Medicare and Medicaid. Medicare is the payer of first resort. So Medicaid is the payer of last resort in all cases, actually.
Yep.
So in those cases, Medicare would pay first, which a lot of times, like for instance, Medicare, if you go in nursing home, it might only pay 30 days, and then your Medicaid kicks in after that. So yes, there are intersections of that, and there are things that we do. We have to be conscious of, well, the impact on Medicare on some things, but
Just bring it up because it adds to complexity of the whole.
sure, yeah.
Do you know anything about the new Medicaid authorities around dual eligibles and integration that just came up January 1st?
I know nothing about them, but it's a great question. But I haven't been following it too closely.
I haven't either. That's why I was asking you. But I do know that there are some new authorities out that are supposed to help with integrated settings and relating to dual eligibles. But I'll send it to you. Maybe your interpretation would be probably a little bit more informed than mine might be. But I know that they're making strides there to make it easier for those populations.
Yeah, and to that point, that population gets targeted a lot because they're a very expensive population. Folks who are on both Medicare and Medicaid have some of the highest spending per capita, we call per member per month, or just overall spending. And so you'll see a lot of, there's some stats somewhere where it's X amount of dollars are spent on X amount of the population. And so a lot of times when we're targeting health interventions, they tend to be towards folks who have higher expenditures and more chronic conditions, and dual eligibles fall into that group of folks who are not a big group. It's I want to say it's somewhere 18 to 20,000 people per se, but they I think it's like $240 million. But I'll get to that slide later on. But it's, yeah.
Can we, I don't know if this is a good place to stop, but one of my goals for this session is that we take breaks more often than we normally do. So if we wanted to